So, pathogenesis and pain in chronic pancreatitis from Sweden.
I would like to continue it in English because probably it's much better for everybody. Thank you very much for the kind invitation and thank you very much for the kind hospitality. It's really good to be here. I got quite a huge topic, clinical management of patients with chronic pancreatitis. I don't want to steal the job for the other presenters or speakers, so that's why my plan is to give a short overview how to deal with that patient, highlighting probably some important parts of the diagnostic and the treatment, according to the well-known German guideline, which was adapted to the Hungarian one done by the Hungarian Pancreatic Study Group. Is it important to talk about guidelines? I think the answer is yes, it is absolutely important. Is it difficult? Sometimes it is difficult to get high evidences for the guidelines. Let me introduce you one example. There was a publication in the British Medical Journal, and they examined whether are there enough randomized control trials to prove if the parachute can prevent death if somebody is jumping out from a plane. And interestingly, there is no any randomized control trial for that. So there is no any high evidence that without a parachute it is quite dangerous to jump out from a plane. However, the guidelines and the evidence-based medicine is very important without randomized control trials also. I just want to highlight one example. This is a Hungarian paper under submission, which showed that if in acute pancreatitis we use as evidence-based parenteral fluid replacement and enteral feeding, then the mortality can decrease from the 50% to 20%. I think there is no need to say any more word. I decided to guide you through the diagnostic and the treatment of the chronic pancreatitis through the story of one of my favorite and very kind patients. So there will be a fairy tale about a 71-year-old male who was working to be presented in my presentation for decades, because in the last century he started to smoke a lot and drink a lot. So probably you can figure out that the problem is the chronic pancreatitis. What does the guidelines say about that? You can see the problem of the evidence-based again, that this is just a 3B level of evidence, and you can understand why. There are no any randomized control trials comparing the smoking and the non-smoking patients, but we know that the smoking can accelerate the progression of the disease. And also the alcohol consumption shows a linear relationship between the level and the duration of the alcohol abuse that is without question. In the 80s, the patient had several acute exacerbation of pancreatitis, or acute episodes of pancreatitis, and finally in 89 the chronic pancreatitis was diagnosed. The diagnosis was based on one side in the exocrine insufficiency. There was more than 10 kilograms weight loss, diarrhea, and steatorrhea of that patient. If we jump to the guidelines about the exocrine insufficiency, it is clear that pancreatic function test should be performed once chronic pancreatitis has been diagnosed. However, the exocrine insufficiency has more or less three typical symptoms: the abdominal pain or discomfort, steatorrhea, and any kind of sign of malnutrition. We have here a wonderful lecture about that. There are some problems, because the development of the steatorrhea and the other symptoms of the exocrine pancreas insufficiency usually is already to be expected at the time of the diagnosis, but become more marked for about 10 years after the appearance. So for example, in patients with alcoholic chronic pancreatitis, the insufficiency usually appears about 10-15 years after the development of the first symptoms. And this is true that the decompensation associated with steatoria does not occur until the secretion of the enzymes has been reduced more than 90-95%. This is known for that publications. From the other hand, exocrine pancreatic insufficiency is also possible even in the absence of morphological evidences of chronic pancreatitis, so it's sometimes really difficult to do the diagnosis. The other key point of the diagnosis is the pain. This patient had relevant pain connected to acute exacerbations and the need for painkillers. We know from the guidelines that the visual analog scale is good for quantifying the pain with chronic pancreatitis. And what I really want to highlight with an 1A evidence as the most effective long-term form of pain therapy is the surgery. There are 2 randomized controlled trials proving that evidence. One of it published in the endoscopy in 2003, and the other one is published in the New England Journal of Medicine, where it was clear that surgical drainage of the pancreatic duct was more effective than the endoscopic treatment in patients with obstruction of the pancreatic duct due to chronic pancreatitis. What kind of imaging techniques can we use for the diagnosis? We performed an ultrasound, which is the easiest one. At that time, we do not have endoscopic ultrasound, so that's why it is in gray. On the abdominal CT scan, inhomogeneous pancreas and the moderate dilatation of the main pancreatic duct was seen. ERCP showed a normal biliary morphology, but an irregular Wirsung duct. We know that after the anamnesis and the clinical examination, the ultrasound scan of the pancreas has to be the first preference. And if there are relevant signs for chronic pancreatitis or the clinical suspicion persists, then the endoscopic ultrasound should be performed. The CT scan, the MRI, and MRCP are very good supplementary diagnostic techniques for the pancreatic abnormalities, but the highest accuracy has the endoscopic ultrasound quite clearly. What I also would like to highlight that in the 21st century, the diagnostic ERCP is not an entity anymore, so should not be, no longer be used because of its higher morbidity and the mortality rates compared to the endoscopic ultrasound or compared to the MRCP examination. I want to show this slide that the endoscopic ultrasound has the highest sensitivity and specificity compared to the other imaging modalities. Back to our patient. In 1992, due to recidivant acute exacerbations, there was a growing pseudocyst, and the distal Wirsung lithiasis proved with persistent symptoms and pain. So what we decided to do is to operate a patient and do a papilla excision, recanalization of the Wirsung duct, and a cystoduodenostomy. Do we do it in a correct way? Hopefully, yes. We know that symptomatic pseudocyst should be treated in endoscopic way or in a surgical treatment, regardless of its size. Usually the initial therapy for the pseudocyst can be the endoscopic treatment, and if there is any recurrence, then a surgery should be performed. There's a paper presented in the gastroenterology that in a randomized controlled trial, the endoscopic and the surgical drainage was equal effective. However, the endoscopic treatment was associated with a much shorter hospital stays, better physical and mental health of the patient, and what is important, also lower cost as well. The asymptomatic pancreatic pseudocyst should also be treated if they do not resolve within 6 weeks and the diameter is bigger than 5 centimeters. Whether transgastric approach or transduodenal or transpapillary I want to highlight that the percutaneous drainage is the last possibility because of the high risk of external fistula, which can be treated in a very difficult manner. If there is advanced pancreatic duct changes presented or associated to the chronic pancreatitis, then probably the surgery would give much better results because the involution is less than 20%. One important thing according to the pseudocyst, that in general the non-neoplastic cysts are only 80% in general. So that means that if there is a cyst presented in the pancreas, 20% is not a pseudocyst, but a malignant one or a potentially malignant cystic lesion, and the pancreas do not mix it. According to the pain, as I mentioned previously, that the surgical procedures and the drainage operations are absolutely superior to the endoscopy procedures regarding to the long-term pain reduction. There is the paper in the gastroenterology what I previously mentioned, and the New England Journal of Medicine also show the same. I don't want to steal the job of my colleagues, so I don't want to go into the details. According to the pain, you have several possibilities to choose if you would like to operate that patient: the Duval, the Pusto, and the modified Pusto operation, and the Tihany operation is known for treating the pain. In 2000, this patient, a biliary stenosis happened. In an abdominal CT scan, the calcification in the pancreatic head was presented with the dilatation of the biliary tree and the pancreatic duct. In an ERCP, we saw an independent pancreatic obstruction of the biliary duct and the typical clinical signs of cholangitis, so a plastic stent insertion happens. And after the solving of the cholangitis, we decided to do an operation, and we do a duodenum preserving pancreatic head resection, secundum frei. If we jump to the guidelines, we see that if there is a calcification in the pancreatic head, then the surgical treatment should be preferred. However, the initial treatment of a biliary obstruction is still the endoscopy. If the patient has cholangitis or the planned surgical intervention cannot be done immediately, then preoperatively an endoscopic stent insertion also indicated. But we have to think that the endoscopic stent therapy is of lasting success more than 12 months in only 1/3 of the patient. There's a publication in the Annals of Surgery suggests that the endobiliary stent should not be used for benign strictures in those patients with a predicted life expectancy greater than 2 years. And the other publication, what I already mentioned, that if the calcification is presented in the pancreatic head, then there is a 17-fold increased risk of failure of a 1-year-long course of endoscopic stenting. What can be the solution for that problem? Probably the hybrid operations, the resections and the decompression together. There are altogether a lot of examples for that: the Frey operation, the Baker, and the Tihany operation also. The publication in the Annals of Surgery showed that the Baker and the Frey operation has almost the same pain relief and the improvement of the quality of life in long-term follow-up. And these techniques can provide as good result as the pancreatic head resection. But the organ-sparing pancreatic head resection has much smaller complication rate, morbidity, and mortality compared to the pylorus-preserving pancreatoduodenectomy or the Whipple operation. Jumping back to a patient, the patient had insulin-dependent diabetes mellitus, and for almost 10 years is effective conservative treatment with pancreatin supplementation, with insulin treatment, and no painkiller necessity. And he lived happily ever after. Unfortunately not. A recurrent biliary obstruction happened with recurrent biliary duct stone. So several endoscopic interventions was performed. Single plastic stent implantation, multiple plastic stents, partially covered metal stents, extraction of the stones, ESVL. But unfortunately, there's a persistent biliary stricture with unremovable stones and guide wires inside the main hepatic duct. Question is what to do. We know that the several stents implantation for distal bile obstruction can be recommended compared to a single stent implantation, and the coated metallic stents can be inserted in case of distal bile duct obstruction, but this one was without effect, unfortunately. And we know that if we need a longer therapy, endoscopic therapy than 1 year, then probably the surgery should be chosen for that one. According to the German guideline, there is a very good clinical consensus point according to the biliary duct obstruction. The shorter the statistical and individual life expectancy of the patient, the higher the comorbidity, the more difficult the foreseeable technical feasibility of an operation. All the more should endoscopic treatment of a biliary duct obstruction due to chronic pancreatitis. And the more the important the lasting therapeutic result, longer the statistical and the individual life expectancy, then the surgical approach should be chosen. So that patient was candidate for surgical intervention. But unfortunately, because of the difficult foreseeable technical feasibility of an operation, because of the marked collateral blood circulation, portal hypertension, surgery was contraindicated. So what we could done is to do a percutaneous transhepatic cholangiography, a balloon dilatation, and a novel intramucosal treatment. So we were able to remove all the stones and dilate these benign biliary strictures with success. So now the patient is without any symptoms for biliary obstruction. How to do the follow-up? It's quite a huge topic. I just want to highlight some sentences of that it is absolutely beneficial to screen that patients, especially the high-risk patients, for development of pancreatic carcinoma. This is the most dangerous problem in chronic pancreatitis, but unfortunately the length of the examination intervals has not yet been clarified. The follow-up, according to our practice as well, the follow-up examination of that patients with chronic pancreatitis should be undertaken every year or twice in a year so that the complications can be recognized in time, usually with an ultrasound examination, but if it's necessary, the CT scan, the MRI, MRCP, and RCP also indicated. The tumor markers has no sense of proving the potential malignant transformation of the disease, so do not do that. So hopefully this is the end of the story now. And I would like to say thank you again for the invitation, and we are looking forward to seeing you in Budapest next year in the EPC. Thank you very much.